Okay, our next speaker, our final speaker for the morning is Dr. Victor Rivera. And boy, our speakers just keep getting better and better and better, from Dr. Lewis to Mardiam, Lieutenant Commander. Dr. Rivera, you're up against a tough group here. But we're so happy that you are coming today to speak with us. We'll put your slide of functional medicine approach for managing chronic pain. Really give us really open our eyes and give us a completely different perspective with the paradigm of functional medicine. I'm very excited about that. And your background, you're a native from Pasadena, Texas, and 2000 graduate of Texas Chiropractic College. And you stayed and worked as a chiropractor before then entering Bachelor of Science Human Biology, Doctor of Chiropractic, after the American College of Acupuncture and Oriental Medicine. And then finally on to medical school at USIS, one of our former pain fellows, and doing a fantastic job in this area. And we're grateful to have you today to talk to us a little bit about functional medicine. Do you like this or that?
No, I'll just do that.
Okay, awesome. All right.
Thanks. All right. All right. Well, thanks for having me, and thank you for Commander Mellon. That was great. So my talk today will focus on how functional medicine can be utilized for the management of chronic pain. Oh yeah, I have no disclosures, and these are primarily all my opinions. So the objectives, to understand the role of functional medicine and how it can be utilized for the management of chronic pain, and then understand the concepts of how functional medicine investigates root causes to create personalized treatment plans, and then become familiar with ways to incorporate functional medicine tools into your practice. So quick background, again, prior to medical school, I went to chiropractic college, and during chiropractic college, we had about a year of clinical nutrition, and that pretty much started my kind of passion in nutrition. And then after chiropractic college, I was working during the day as a chiropractor and going to school at the American College of Acupuncture and Oriental Medicine in Houston. And in there, I kind of learned how food is utilized for just management of all diseases and stuff. So then that kind of helped to hone in some of kind of my nutritional background. Then I decided to go to med school, and in med school, I kind of lost that emphasis. I remember getting a nutritional book that was about this size during one of our intersessions at USIS, and that was it. We were told, hey, if you're interested in clinical nutrition, there's a book that you can get in the admissions office, and that was our course. So then graduated medical school, went to internship, and then after internship, this is where it really all started for me. I was at the flight surgeon course and got a call that my daughter had a seizure. Then she was worked up, and it was idiopathic. She was having a seizure every 20 minutes. And it would start at different locations, so she didn't have anything structurally wrong with her. They did a full workup, tried her on all these medications. She was refractory to all the medications. And then for the last ditch effort, they decided to do the ketogenic diet on her. Well, after a few weeks, her seizures stopped. So they decided to start weaning her off probably about the 3-month mark. And then as they began to wean her off, the seizures returned. So they kept her on the ketogenic diet for another 1.5 years. And at that point, they were, she'd been drinking oil for meals, and she was 7 at the time, and very, very little carbs. And anyway, she started talking about all the foods that she wanted to eat after coming off the diet, and I was like, whoa, this can't be good. So I started doing a lot of research, one, to figure out why that worked, and then 2, how she could protect our brain, all right, from this occurring again. So in my research, I kind of got exposed to how powerful nutrition is into treating not only seizures, but all kind of all disease states. And I read a book called Ultramind by Mark Hyman, who's a board member of the Institute of Functional Medicine and also the director of the Cleveland Clinic Center for Functional Medicine. And that book really opened my eyes as far as how functional medicine is used to kind of help patients recover from not just seizures, but just really from all ailments. So that really kicked everything off. Next slide. So what is functional medicine? Well, it's an approach to medicine that addresses the underlying causes of disease using a systems-oriented approach and engaging both the patient and the practitioner in the therapeutic partnership. Now, what does that really mean? It means getting the patient involved in their health and their recovery, and moving from kind of a passive patient to an active one where they're involved in their self-care. And that's really where the benefit of functional medicine comes in, is that you get the patients involved in their own kind of care. Okay, the first lecture on functional medicine, so it's not a kind of modern phenomenon. This Dr. Willoughby Wade, he's an English physician, and in 1870 he gave a clinical lecture that was published a year later in Lancet, and in that he says, so can you click? Sorry. So what is disease? In old times, people used to think that a disease was some actual entity or thing which had gone into the body in some way and was there lying hidden and secreted and was to be cast out. This idea, which we know to be true only in a few specific instances, was the one-time general. The conclusion is that all disease is disordered function. And he goes on to say that here, then I say, is the highest justification for all treatment being based upon the principle of restoring disordered functions to order. And this is what I have ventured to term functional medicine. Next slide, please. And so, again, it's been around for a while. But in '89, Dr. Bland, who is one of the co-founders for the Institute of Functional Medicine, got a group of 40 physicians and naturopaths to discuss and kind of go over what the idealized healthcare system would look like. And about a year later, he coined the term, from this meeting, he coined the term functional medicine. And then in 1991, Dr. Bland and his wife, Susan Bland, co-founded the Institute of Functional Medicine. And I like this quote from him that he just gave here recently, or this year, that the only way you can quantify health is through its function: physical, metabolic, physiologic, and cognitive, being behavioral or psychological. So functional medicine is patient-centered rather than disease-centered. It acknowledges biochemical diversity and individuality. So it investigates and addresses genetic, lifestyle, and environmental determinants of health, addresses the root cause rather than symptoms, and empowers the patient and practitioners to work together. And then treatment targets the specific manifestations of disease in each individual, right? So we're all kind of individual, we're all different in many different ways. Not only from genetic, like the biochemical diversity, but also our microbiome. So about a third of the microbiome we all have the same, but 2/3 is different in all of us, and in that we kind of process foods differently. So you need to tailor treatments, and specifically like nutrition, per patient. It's not just a cookie cutter, here, try paleo, here, try this. It's all dependent on how they metabolize food, and we'll go over that here soon. So, like Dr. Mardian, sorry I butchered your name, said that the cost of chronic diseases is pretty high. In this article they talk about how 90% of the 3.3 trillion that's in annual healthcare expenditures are due to chronic and mental health conditions. In managing those symptoms, and managing symptoms when prevention is not possible, and then preventing those chronic diseases is kind of where we need to focus, and that's where I think functional medicine really plays a big role in. Next slide, please. This slide is similar to what we heard earlier, that over 100 million adults suffer from chronic pain, and greater than 600 billion is the annual cost. And this was back in 2011, and you can imagine that today is probably a little bit more. And of those chronic conditions, back pain, neck pain, joint pain, arthritis, musculoskeletal disease, migraines, you can see that those are the big majority of people that actually are kind of a little frustrated with the allopathic medicine of kind of symptom treatment and looking for other alternatives and looking for complementary alternative medicine to see if they can find treatments for that. So in chronic pain, we should be looking at this paradigm shift where we the treatment should focus on functional restoration, resiliency, as was mentioned earlier, and wellness, and not just on the pain or pain treatments. Finding and treating the root cause through whether that's anatomic, autoimmune, neurodegenerative, metabolic, or psychological disorders. And then empowering the patient for effective pain management, having the patients take ownership of their lives and their care, really. And that's key. And we'll go over that a little bit, too, is about how the VA model is really kicking that, or starting that program really well. So root causes of chronic pain, kind of the main culprit is how lifestyle, environment, and stressors kind of interact to affect genes, and they affect genes this way through what's called epigenetics. And basically, we will turn on or turn off genes based on everything we experience, from the food we put in our bodies to any psychological stressors, physical stressors, and then environmental exposures. And then looking at imbalances which may lead to increased inflammation. And as you can see here, the imbalances can be either one condition with many imbalances, like inflammation, hormones, again, genetics and epigenetics, diet, exercise, and mood disorders can all lead to chronic pain, or you can have one imbalance with many conditions like inflammation, where you can have heart disease from that, depression, arthritis, cancer, and diabetes. So looking at these clinical imbalances a little bit further and how they're utilizing the functional medicine matrix, you look at assimilation, digestive, whether the patient is having some digestive problem, an absorptive, or the microbiome imbalances, right, with small intestine bacterial overgrowth, where they're having bloating after certain meals. And these are things that you can all tease out based on the history and stuff, and we'll go over that and how you implement that into the timeline and then into the matrix. Defense and repair, immune and inflammatory imbalances, energy, oxidation and reduction imbalances, and mitochondrial dysfunction. Biotransformation and elimination, which involves the detoxification pathways. Communication and circulation, which involves hormonal and neuroendocrine. Transportation, which is cardiovascular and the lymphatics. And then structural integrity, which imbalances in cellular membrane function and the musculoskeletal system. So the functional medicine approach really involves two important questions, right? Does this person need to get rid of something? or does this person have some unmet individual need required for optimal function? And the primary causes of disease, or what do you need to get rid of, or what does this patient need to get rid of? And you have to start thinking about toxins that, especially in the military community, that they're exposed to, right? Burn pits when they're deployed, lead, you name it, all kinds of stuff. Allergens, food, mold. Mold I would kind of consider being with toxins as well. Dust, animal products, pollens, and chemicals, microbiome, or the microbes, bacteria, ticks, yeast, parasites, and viruses. Stress, physical. Now, in the military, that could be even overtraining with these young kids that think they're invincible and they want to do high intensity or Tabata 4 or 5 days a week and not allowing their body to rest. And as they repeatedly do that, they create this stress and weakness that they leave themselves prone to injury. So educating them on that is crucial. And then psychological stress, and again, poor diet. Then what do you need to get to thrive, right? So nutrient-dense foods that are high in vitamins, minerals, essential nutrients, light, exposure to light, so they're creating their own vitamin D. Water, purified water. If they're drinking a lot of tap water that's high in chlorine, how that affects the microbiome. And then air quality indoors. Getting an air filter at the house. Movement, rhythm, basically trying to stay consistent in their kind of normal day-to-day functions so they can be optimized into the kind of circadian rhythm and then so their body is functioning optimally. Social, love, community, and connection. Today with social media, that connection is, they got thousands of friends online, but they're at home alone, right? And that builds up to where they're less resilient. They start developing depression, and they're just prone to chronic pain and chronic diseases. And then having meaning and purpose, which we've kind of touched upon today already. So where to start? So in functional medicine, they use these steps, the go-to-it steps, and we'll go into these in a little bit more detail. But gather oneself, and then gathering information, organizing that information into the matrix, which we'll go into here in a little bit. Tell the patient's story, and then the order of your priorities based on where they're having most of their imbalances and how you're going to initiate assessment and care from that, and then how do you track the progress. So in gathering oneself, like we've all had the patient where we have to take the big sigh, take a step back before entering the room because they're very difficult. But this is crucial to where you go into the room, you have a good positive attitude, right? Went to NANS 2 years ago, and just the power of suggestion is key. You just telling a patient, I'm in pain management and do a bunch of procedures. Just telling the patient that they're going to benefit from a procedure, they already start descending inhibitory pathways without me even touching them. They've already started the improvement, right? So just telling patients and being positive when you're in a room is crucial. And clearing your mind and getting that negativity, like, oh my God, I got to see this patient again. Just it's crucial that you clear your mind before going in, right? Take a deep breath and just calm yourself down and try to think positively as you go into the patient encounter. And then gathering the information and applying that information on the timeline, the functional medicine timeline, which we'll kind of go over here in a little bit. And then organizing all the information that you gather from that encounter into the matrix so you can come up with treatment plans. And we'll go over that here in a little bit. So antecedents, triggers, and mediators. So antecedents are factors that are either genetic or acquired that predispose individuals to an illness or a pattern. Triggers are factors that provoke the symptoms and signs of illness, and then mediators are factors, biochemical or psychosocial, that contribute to pathologic changes and dysfunctional responses. And I like this acronym, STAIN, because it kind of helps you. I usually take this into the room with me, and it lets me kind of not hone in, but just triggers or reminders of, hey, what things I may need to ask. So for the S, stress, sleep, the more I've been here recently reading, sleep is, I used to think nutrition was number one, but I've kind of changed that to kind of sleep. And we'll discuss why here in a little bit. And then single nucleotide polymorphisms. I know I haven't really talked about that, but just genetic changes that make us kind of different between everybody. The T stands for trauma, toxins, and tablets, whether they've been taking antibiotics, steroids. A is for antigens, allergies, and autoimmune disorders. I is for infections or ingestions. Nutritional excesses or nutritional deficiencies, and then D for dysbiosis and kind of digestion. So this is the functional medicine timeline. And this is how you organize the information that's gathered from the patient encounter or from just the chart review before entering the room. You can kind of put some things down on here and then maybe some, hey, I need to ask about this. And it just helps you organize, but it's also an effective tool when you go back and you tell the patient's story back. You can show them here on the timeline, hey, look, this is things that you're kind of predisposed to. These are some of the mediators, and these are some of the triggers. Next slide, please. And this is what kind of an example of what a timeline would look like, right? You go through the antecedents, what family history they have, if they had diabetes, if there's a long-standing history of hypertension, things like that. And then the mediators, whether they're on the standard American diet, which is highly pro-inflammatory and high glycemic index and load diet, what their alcohol intake is, whether they have a sedentary lifestyle. And then triggers, toxin exposures, infections, pharmaceuticals. And then you can put this timeline together and then ask the patients, hey, when was the last time you felt well? And then you can tell the patient's story back, and you can explain how all this plays a role and how you can organize this to kind of come up with a treatment plan later on. So the next step is tell the patient their story back. And this is kind of crucial to kind of let the patient know, one, that you were listening, and then two, that it lets them know that you care, and that would kind of help build rapport and compliance to any kind of treatment plan that you have going forward. And then the order of prioritization emerges from the dialogue that you have with the patient. What's important to the patient? Maybe that's a starting point for your treatment. And then you put all that information into the matrix, and then you can, next slide. You put that into the matrix so you can see where, and then next slide, where all the ink is, where they're having most of their problems, and then that helps you to kind of focus your kind of treatment plan. And then the next steps are initiate and track. So in the initiation, right, you initiate treatment. You can either do further assessment with some lab works, but I find that you usually don't have to do that. You have enough information to at least start, and then if you need to, upon follow-ups, you can look at further assessment, whether labs you may need to get or other labs that you may need to get. And then tracking any progress with the medical symptom questionnaire. You can do a sleep log, a food log, something that shows some progression. And then as they see a benefit in one area, they're more likely to take your considerations with other areas to help improve their overall health and decrease their pain. So things to consider when you initiate therapy is the chronicity and the severity of their disease or the pain. Reduce any triggers or triggering events. And then in functional medicine, they do the food first approach, where most will talk about an elimination diet or a low glycemic index diet, but it's very difficult to kind of start off that way. I usually don't, and I'll talk about how I kind of approach this here a little bit later. And then address optimal function of the organs and elimination, and then apply specific medical and functional foods, vitamins, minerals, antioxidant nutrients to support nutritional balance, and reduce inflammation and increase vitality, and then consider personalized maintenance plan. So in this example, if I were to take the matrix in and it's all filled in, and if I wanted to start off with nutrition, then I use this as an education tool as well as how nutrition plays a role in all aspects of whatever most of their imbalances are happening in the matrix and from what they've told me. Next slide. And then you can track their progress, again, using either a sleep log or a food log, or at each encounter you can use the medical symptom questionnaire, where you have a bunch of questions that they answer, and with each follow-up you hope to see some improvement, and then you have a positive kind of or a reinforcing kind of tool that, hey, we're on the right track. Look, yeah, your pain may or may not be better, but look at your overall quality of life is improving. And then as you continue, that's where you will start to see the improvements in chronic pain. So collaborative care team, like the Lieutenant Commander mentioned, collaborating with not only the physical therapist but the nutritionist and any health coaches is key to ensuring that this model kind of provides the best benefit in patient care. So kind of my approach to functional medicine in the management of chronic pain. So before an encounter, I will review the chart and I'll look for certain things right on the timeline, kind of cues to ask, see if they have any gastrointestinal disturbances, see how many GI appointments they have, or see what their kind of problem lists, go through that and see what they've kind of been going through. Look at any inflammatory arthropathy or disease, or any type of inflammatory disease that they may have, like diabetes. See if they have insomnia, which poor sleep can just intensify pain just in and of itself. Mental health encounters, and then if they're a fibromyalgic patient, or if they haven't been given the diagnosis, you can easily kind of review their chart and be like, yeah, have them fill out the severity symptom questionnaire. And then look at previous labs, and then what medications they're on, because there's a lot of medications that it can have some deleterious effects, or some effects where they cause deficiencies in a lot of the vitamins and minerals. Just for instance, like metformin can cause a deficiency in B12. Statins can cause CoQ10 deficiency. All right. So during the encounter, I'll make general observations of the patient. What their demeanor is, what they look like. Are they disheveled? Do they look like an inflammatory patient? If they're tired, if they look sleepy. And then put the history on the timeline and do my examination and looking at the hair, their skin, and their nails. So not just, oh, hey, I'm here for back pain. I kind of look at everything real quick and kind of start formulating other questions that I may ask them, and the treatment plans. So I initially, when I first started off, probably a year and a half ago now, with functional medicine, I kind of threw too much information at them, and I just wanted to, I got all excited, and I wanted to start off with everything. Oh, we got to improve your sleep, we got to improve your exercise, movement, nutrition, everything. Well, that's too much, right? Most people will kind of tune out after the first thing, and they're like, oh, this guy's crazy. He wants me to do what? So now I just focus one thing at a time. So during the encounter, you want to identify reversible causes. And one of the main things I ask is about sleep. And poor sleep, it'll increase pain intensity. It decreases testosterone in men, causes insulin resistance, especially if you're sleeping around the 5-hour mark. Two good books to read is Why We Sleep by Matthew Walker, and Sleep Smarter by Sean Stevenson. And they go over the Matthew Walker book goes over the Why We Sleep, goes over all the kind of science and all the research that he's done for the past 20 years on how sleep affects everything, right? It'll cause depression, it causes inflammation, it causes an increase in pain intensity, causes cardiovascular disease, memory, dementia, you name it. And improving sleep just alone will just decrease the pain intensity. And there's a bunch of things that you can incorporate to help patients sleep. We know about the sleep hygiene. That's just one aspect, but there's other ways to kind of help with sleep. And when we go through, if you signed up for the functional medicine workshop, we'll go through that in detail. Biomechanical and myofascial. So if they have myofascial type of pain, I definitely recommend yoga if they can do it, if their pain doesn't inhibit it. If it does, then just small movements, maybe a foam roller. It doesn't have to be over the painful area. They can just start off just standing on it, doing the back of their legs, their arms, whatever it is. And like Commander Wilm mentioned, it's all connected. And there's another good book, and it's on fascia. And if you're interested in it, I'll get you the name of the book, on the myofascial plane. But yoga, as well as electroacupuncture, will stimulate stem cells in that myofascial plane that will help with myofascial kind of remodeling and helping with kind of myofascial pain states. Nutrition and metabolic, and then stress reduction, meditation, and then relationships, right? If your patient is secluded or they're closed off, they don't do anything in the evenings, try to get them involved in a group, whether it's a bowling league or wherever, something. They need to get out, make connections, because that alone will help to start kind of help reduce some of the pain intensity that they feel. This is a good article that kind of goes over how diet and stress are responsible for chronic inflammation, and then how chronic activation of the central axis, the stress axis, disrupts the body's ability to resolve that inflammation. And I use two charts in this for kind of patient education when maybe on a follow-up, not the initial visit. Again, I don't want to bombard them with too much information, but if they've shown improvements in either sleep, or how I really start patients off is with time-restricted eating, they come back in 4 weeks, 6 weeks, and if they have improvement, then I'll go, awesome, now let's move on to how what you eat can also influence your pain states and stuff. So then at that point, I'll emphasize the importance of high-quality foods, that are rich in phytonutrients, that are diverse, and can address some of the clinical imbalances, and really educating the patient on what works for them, okay? Because I can eat a cup of rice and my blood sugar goes through the roof, but my wife can eat a cup of rice and her blood sugar kind of remain normal, right? part of that is from what I discussed earlier on how the microbiome, about a third of it is about the same, but 2/3 of it is completely different. There's a good article that the Israelis did, and it was an 800 cohort, and they showed how everybody in that cohort had different 2-hour postprandial glucose responses to the same foods. So having a cookie cutter approach to, hey, just follow an anti-inflammatory diet, just follow paleo diet, Mediterranean, that might not work for the person that's in front of you. So one of the things that I kind of suggest, and this is later on, is that they monitor their blood glucose 2 hours after their meals. And if it's above 140, then whatever the carbohydrate that they had in there, you know, it may be different from their spouse, their kids, or whatever. They would just either have to limit it or eliminate it from their diet to maintain a normal blood sugar, and then you don't get the insulin spikes, which can cause inflammation and make their pain worse. And that's how I kind of try to educate them on that. So this is how I start off most patients, and I'll start them with time-restricted eating. It's a form of intermittent fasting. I know Dr. Sachin Panda doesn't like it being termed intermittent fasting, but you are restricting your eating window within a certain time period. And it's based all on the circadian clock, right? The circadian rhythm that we all kind of go through. And most of the digestive aspects of kind of processing food, your digestive enzymes, the liver, pancreas, everything is on a circadian rhythm. Even the microbiome is in a circadian rhythm. And it all gets kicked off once you start to get exposed to light, really sunlight, and above 10,000 lux. And we have receptors in the eyes called melanopsin, and it sends a signal and it activates all this stuff. So foods are processed better earlier in the day than they are in the evening. And you can have the same meal and this is what I tell patients, you can have the same meal at 9 in the morning and that same meal at 1800. And your response is going to be completely different. You'll have a higher blood glucose, higher insulin response in the evening, even though the meal is exactly the same. Most of that is due to the kind of the circadian rhythm that we have in our body. And as the sun starts to set, your melatonin increases, and if you're exposed to blue light in the evening, you will stop that melatonin production, and you won't get into deep sleep, and you'll also inhibit the kind of rest and repair of your digestive tract as well, especially eating eating at night. So I usually recommend daytime eating only, and I try to explain to the patients that to stop eating 4 to 5 hours before they go to bed, so that they can get into deep sleep as well. Because if you eat too close to bedtime, then you won't get into deep sleep, and you can find out that information once you read the Matthew Walker book, Why We Sleep. But it also it's more of an inflammatory burden when we do eat at night, because our body's getting ready to go to sleep, and it's supposed to be going there to rest and repair, not to digest all the food that you have just eaten. So you have kind of talked about the improved insulin sensitivity with earlier eating, and then eating at night increases inflammation and disrupts sleep. And then, so they did so Dr. Sachin Panda also did some studies on night shift workers and what their effects is if they incorporated, now this is what I consider the intermittent fasting, because if they're working at night, they're eating at night. And what they found was decreased markers of inflammation and better, and kind of reduced pain and just better responses, even if they're eating at night, but as long as they restrict that window down to like 8 hours or less. Next slide. So sleep. Now this is from one of the articles that Matthew Walker has put out, and also from his book, but chronic sleep restriction increases pain sensitivity. So I tend to really push sleep hygiene, and some of the things like wearing blue blocking glasses in the evening, so about 3 hours before they go to bed, just to put blue blocking glasses on that they can find really cheap, like $12 on Amazon. Start dimming lights 3 hours before they go to bed, and then cool the room down before they go to bed as well. So ideally, from what the research that Matthew Walker has found, is that you want to set the temperature down to 65 degrees so you can cool the body down about 2 degrees, and that'll help you get into deep sleep, which will help with recovery. It helps the lymphatic system in the brain as you get into deep sleep, so it drains the brain from the neurotoxins and the inflammation from the day, and overall helps. There's some question on whether sleep apps do help. If they help for a person, great. If they don't, I just don't recommend them. So at follow-up appointments, I kind of reinforce positive gains. I encourage another aspect of the modifiable personal lifestyle factors. So if we focused on sleep the initial visit, and they have some positive results, great. Then I'll move on to either time-restricted eating or go into kind of an inflammatory type of diet, and then kind of explain how they have to figure out what's best for them. And again, that's with the personalized diet versus the elimination diet. Now, the elimination diet I usually won't go into until about the third or fourth time that I've seen them. If they start seeing some good results, but they're still not where they want to be, then maybe an elimination diet would be best for them, and then we'll send them to their nutritionist to go over the elimination diet. Order labs only if they're pertinent, and I'll go over some of the labs that I order if I need to, and then some of the supplement suggestions, but that's only if they just don't change their diet and they have this super poor diet, mainly from processed foods. So some of the labs that I get a fasting insulin, and anything around 8 or above I consider high, even though the normal here you can see is 45 to 40. Most of the stuff that I've read states that you may be pre-diabetic even with a fasting insulin above 8. And then Dale Bredesen, who's kind of a pioneer researcher on Alzheimer's and dementia, he likes to have the fasting insulin less than 5, just because of the inflammatory effects that it has, and then that the patients are kind of using a high glucose, kind of high carb diet, which has been shown to kind of be deleterious to the hypothalamus and cause neuroinflammation. Then I look at vitamin D, which is helpful for reducing glial cell activation, and want to keep that around 40 to 60. Ferritin, which is important for the mitochondrial electron transport chain, want to keep that around 40 to 70. And then RBC magnesium, which is kind of an intracellular magnesium level, and that's important because magnesium's an NMDA receptor antagonist, and also involved in over 300 metabolic pathways in your body. And the optimal range is about 6.0 to 6.5 milligrams per deciliter. Homocysteine, like to keep that less than 7 micromoles per liter, because if homocysteine's high, it'll activate glutamate receptors and kind of increase your pain intensity from that. And then high sensitivity CRP, and want to keep that less than 1. If I do recommend supplements, and depending on their level, if they even need it. If they're low in B6, I'll give them B6 because B6 helps to convert glutamate to GABA, which is an inhibitory pathway in the central nervous system and can help reduce chronic pain that way. Vitamin D, again, reduces glial cell activation. If I put somebody on vitamin D, I'll always add vitamin K2. Just simply placing a patient on vitamin D, you're actually increasing their risk of calcification of the arteries and cardiovascular disease. So if you're giving a patient vitamin D, please add vitamin K2. Vitamin K2 is utilized with to ensure that that calcium gets intracellularly and not into the arteries and into joints. Coenzyme Q10, I will recommend that to any patient on a statin, and it just improves mitochondrial function. It's important. It's in between the phase 1 or phase 2 and 3. Magnesium, again, an NMDA receptor antagonist, and then a methyl B complex or a methylfolate, B12, B2, and B6, which is important for that methylation pathway, which will convert that homocysteine into methionine and cysteine. Remember that homocysteine activates glutamate receptors, which will intensify pain. And then zinc, if they need it, right? It's an NMDA receptor antagonist as well. So how do you implement this in a 15-minute encounter, right? It's kind of quite a lot, I know, and you're probably going, what's this guy talking about? Come on. Just utilize it as a stepwise approach, right? I tell patients we're going to do this in baby steps, right? We're going to start off with one. You're going to get great results. That's that positive kind of Jedi mind trick on them. Like, hey, you're going to do great. Once we build up on this, then we'll add something else. But I still give them my sheet that I usually give to patients, and it's got like tons of information on there. In case occasionally you'll get that motivated patient that just wants to do everything that you kind of mentioned. So I'll give that sheet out to everybody. And then at follow-ups, I'll say, okay, I usually note it in my note, hey, we talked about time-restricted eating, or we talked about whatever, sleep, and then that way I know what to discuss next. And then the other thing is motivational interviewing, finding out what's important for that patient, and then not dictating what they need to do, but, hey, what do you think about, improving your sleep, and how do you think you can improve it, right? Again, the Jedi mind trick where you're kind of getting the patient involved and, hey, it's their idea, and you're just kind of, yeah, that's great. Let's try that. And then if you're saying the same thing to every patient, it's best to do it in a group. And the Veteran Administration is doing this whole health concept. And it's kind of it's changing the way we're doing it at kind of incorporating functional medicine in Portsmouth. Next slide, please. So this whole health concept, I'll have the link on the next slide, but Dr. Henry Roca, who's at the VA in Little Rock, Arkansas, fabulous. He did a Institute of Functional Medicine Grand Round, I think back in April. Highly recommend you watch it. It's about an hour long, but well worth your time. He goes over the benefits of doing, so in this whole health model, it's patient-centered, that mindfulness, awareness, but they utilize health coaches primarily. And what they'll do is that if they have a chronic pain patient, they'll send them through this 9-week course before they go see a pain management specialist or their PCM, or they'll follow up with their PCM after the 9-week course. And about 70% of those patients they'll opt not to go follow up with either a PCM or a pain management physician. And what they focus on is resiliency. They focus on self-care and things that they kind of can do for themselves. Highly recommend the video. It's great. It's a great adjunct to this lecture, or just in and of itself. Again, so they utilize that group visit framework. Again, if you're saying the same thing to different patients, just create a group. And if you watch that video, you may get an idea of, hey, I think we can incorporate this at wherever clinic that you're from. Next slide. Here's some of the resources. There's that link to that Grand Round, which I can't recommend it enough. Some military resources, the Mill Suite. Amy has developed and Dr. Spivak developed a functional medicine group on Mill Suite. So if you want to just get on there, get some ideas. Hey, you have a question on a patient, get on there, and we'll have a conversation and give some ideas on how to do that. And then there's a functional medicine webinar every first Tuesday of the month from 1500 to 1600 Eastern Time. These are some of the podcasts that I listen to kind of help increase my knowledge. And so the Found My Fitness I love because she's obsessed with everything anti-aging, and everything anti-aging is anti-inflammatory, which will help with pain. But she interviews all the researchers that are doing the actual research now, so you can kind of get ahead of, not wait 15, 20 years before the medical community says, oh yeah, that might be a good idea. You can kind of be ahead, and maybe you're N of one here, N of one there, N of one over here. We can all collaborate and kind of be on the forefront instead of waiting 2 decades behind. Also a plug, Dr. McClanahan has done a grant proposal for a functional medicine research project, and if you're interested, we want to do a multi-site, so if you're interested in getting involved in that research, just get in contact with me at some point this week, and I'll get your information, and we can kind of stay in touch on that. All right, thanks.
Thank you, Dr. Rivera. That was an absolutely fantastic talk. We really appreciate that wealth of information that you bring from your perspective, and again, also making that plug for anybody that's interested in that multi-center study with Dr. McClanahan. So keeping on time, we're going to break now for lunch. So please be back at 1300. Remember, lunch is served in the building behind us. If you have pre-ordered, please pay and get your pre-order. Otherwise, there's AWOL and other options there. And again, that's in Building C right behind us. And our speakers will all be available up front if you have any other questions. If not, we'll see you at 1300. Thank you, everyone.